Hey guys, Shamir. Today I'm going to teach you how to perform a lower extremity venous duplex. Start by placing the patient in the supine position with their leg frog to the side. If the patient can't roll their leg, then try having the patient slightly roll towards the affected side. That way, this will position the patient in the frog-like position as much as possible without having them actually frog their leg. Start by placing the transducer in your patient's groin with the index pointing towards the patient's right side. This will be the same for the left and right leg anytime you do a transverse view. If you don't see anything right off the bat, you might be too lateral respectfully. So just take your transducer and move it more medially until you start seeing dark anechoic circles. The first vein you're going to evaluate is the common femoral vein. One thing I always tell my students is that once you place your transducer in the groin, if you're not 100% uncomfortable, you're probably in the wrong place, because the common femoral vein is actually more proximal than you think. Start by moving the transducer more proximally until you see the greater saphenous vein branch off of the common femoral vein. You'll stop there and you'll start compressing to make sure that the vein is patent and unobstructed. Now turn your transducer 90 degrees with the index pointing towards the patient's head. Turn on color. This is where you're going to start augmenting from a distal region. The huge advantage of augmenting is that when you're looking at any specific vein and you augment distally, this will tell you if anything is obstructed from where you compressed to where you're imaging. So if you're looking at the common femoral vein, and let's say I augment on the patient's calf, and I see a good augmentation flow, that means the chances of having an obstruction between where I'm scanning and where I'm augmenting at the calf are minimal. You can still have a chronic DVT that's not occlusive and still augment flow, but at least you know that you probably won't have an acute DVT. You can have DVTs in other places that don't have a direct channel from the popliteal to the common femoral vein, but at least you'll know that that pathway, that main pathway, is probably patent. That being said, you still need to check the entire leg, because some patients will develop an extra popliteal vein and an extra femoral vein because those veins were blocked with acute DVTs. So the body created new veins to create another channel from where it was obstructed distally to more proximally. Even though augmentation is good to determine if there is a DVT between where you're scanning and augmenting, you shouldn't use that method as your final decision as to whether there's a DVT or not. With your transducer in the same position, you're going to turn on spectral Doppler, place your pulse wave in the common femoral vein, and this is where you're going to record an augmented spectral Doppler. And this waveform here indicates a normal augmentation. Next, we're going to evaluate the saphenofemoral junction, which is slightly distal to the common femoral vein. So move your transducer slightly distally until you see the greater saphenous vein branch off of the common femoral vein. Now, the greater saphenous vein is a superficial vein, and if you find a clot in this vein, it's called a superficial thrombophlebitis, which is not dangerous. But if you see a clot extending from the greater saphenous vein through the saphenofemoral junction and into the common femoral vein, this is considered a deep vein thrombosis. While your transducer is in the transverse view, start by compressing the saphenofemoral junction to make sure it's patent and not obstructed. Then turn your transducer to the sagittal view, or the long axis, with the index pointed towards the patient's head. Turn on color. Then augment with your other hand by compressing the patient's thigh. Then turn on spectral Doppler, put your pulse wave in the saphenofemoral junction, and acquire a spectral Doppler image of an augmented spectral Doppler. Next, we're going to look at the deep femoral vein, or the profunda femoris vein. And this vein can be extremely difficult to find, even for seasonal sonographers. There's a couple different ways that will help you. And the first way is to leave your transducer in the sagittal view, turn on color Doppler, and move slightly distally until you see the common femoral vein bifurcate into the femoral vein and the profunda femoris. The deep femoral vein will dive down to the bottom of your screen. If you still can't find it, slightly move your transducer more distally, and if that doesn't work, turn your transducer to the transverse view, increase your depth a little bit, and that way you'll be able to see on your screen, hopefully, 4 circles. The 2 top circles represent the femoral artery and the femoral vein. If you still can't see the deep femoral vein, try compressing the transducer up and down, and hopefully you'll start seeing a couple circles compressing and decompressing. Turn on color so that you can distinguish between the artery and the vein, because an artery will have more pulsatile flow and won't compress, while in a vein you'll see more of a respiratory phasic flow. Now, the deep femoral vein won't be one of the 2 top circles, but it will be one of the bottom 2 circles. And obviously it won't be the circle that has high pulsatile flow and that's not compressing, as long as there's no DVTs. Now that you've located the deep femoral vein, rotate your transducer back to the sagittal view, leave on color, and acquire color Doppler images of you augmenting the deep femoral vein by compressing the patient's thigh. Next, we'll turn on pulse wave Doppler, put it in the deep femoral vein, and then acquire another spectral Doppler image of you augmenting the deep femoral vein. Next, we're going to look at the femoral vein, which used to be called the superficial femoral vein. And that vein is going to be at the top of your screen. You'll see it as it bifurcates off of the common femoral vein, but it's actually for board purposes converging into the common femoral vein. The deep femoral and the femoral vein converge into the common femoral vein. Once you see the two veins bifurcate, put your transducer in the transverse view at the proximal femoral vein. Start by compressing the femoral vein to prove that it's patent and not obstructed. Turn your transducer to the sagittal or the long axis view, turn on color, and acquire images of you augmenting the femoral vein. You'll keep your transducer in the same view, turn on spectral Doppler, put your pulse wave in the femoral vein, and acquire a spectral Doppler image of you augmenting the femoral vein. You're going to repeat those steps for the mid-femoral and the distal femoral. The femoral vein will extend from the prox thigh all the way down to the distal thigh right before the knee. Next, we're going to evaluate the popliteal vein. Start by placing your transducer with the index pointing superiorly behind the patient's knee. This will orient the popliteal vein and artery in a transverse view. Start by compressing the vein, then turn your transducer so you're in the sagittal view where the index is pointed towards the patient's head. Turn on color, then augment flow in the popliteal vein by compressing the calf. Then turn on spectral Doppler and acquire an image of you augmenting flow through the popliteal vein. You'll repeat these steps in the mid and distal popliteal vein. Right around the mid-popliteal region, you'll see the small saphenous vein connecting to the popliteal vein. This is another area where you want to check to see if there's any blood clot from the small saphenous vein protruding into the popliteal vein. If that's the case, then this will be called a DVT. Next, we're going to evaluate the greater saphenous vein. So what you'll do is go back up to the saphenofemoral junction. You'll acquire images of 2D compression, color Doppler, and spectral Doppler in the prox thigh, mid-thigh, and distal thigh. The greater saphenous vein is the longest vein in the body, and it'll extend from the prox thigh down past the knee and distal to the calf. What I like to do is look at 3 regions above the knee and 3 regions below the knee. If you're having a difficult time finding the greater saphenous vein, start from the saphenofemoral junction, move distally while keeping the vein in the middle of your screen. And the vein's going to run more medially in the patient's leg, so double check your positioning because you might be too lateral. You might have to move your transducer more medially on the inner side of the patient's leg. What you're looking for is the Egyptian eye sign, where the greater saphenous vein in the transverse view will literally look like an Egyptian eye. If you're doing all these tricks and you still can't find it, chances are they might have had that vein removed. A lot of patients are getting their greater saphenous vein removed to treat their venous insufficiency. So if you notice that it's taking longer than normal to find the vein, just ask the patient if they've had any veins ablated, because chances are they might have had that vein removed. Before you leave this area, make sure that you check the gastrocnemius veins, and those are located if you put your transducer right on the patient's calf. You will usually see a few of those in the gastrocnemius muscle. Next, we're going to move to the posterior tibs and the perineal. I usually like to start distally, so I'll put my transducer right at the distal area, right by the medial malleolus in the transverse position. I'll compress distally with 2D, then I'll move my transducer to the distal calf. This is about the mid area, and I'll acquire 2D images with compression. Once you compress the veins with the transducer, turn your transducer to the sagittal view or the long axis view, and the best position to place your transducer is right along the line where the muscle meets the bone. Turn on color, and you'll usually see the posterior tibs when you kind of fan anteriorly. Then you'll see the perineals when you angle your transducer more dorsally or posteriorly. Turn on color and acquire images there. And then compress the veins more proximally or proximal calf to make sure that this area is patent as well. While you're at the distal calf, check the soleal vein. The soleal vein usually will come down and will connect either to the perineal or the posterior tibs. Thank you so much for watching. We'll see you next time.